One of the problems of having a name like Van Overschelde is that nobody can pronounce it. Even sometimes myself have a trouble reminding how I'm named. Okay. The nice thing about mitral valve repair is that for the first time the echocardiographer has to do something interventional, particularly for the mitral clip, since the interventional cardiologist now is the joystick of the echocardiographer, and I like this situation very much. This talk is going to be brief because, of course, these are relatively new techniques. The experience of everyone is usually relatively limited. So what I'm going to review with you are the echocardiographic criteria essentially for the mitral clip, since the other techniques are still very investigational. I will show you some images of the echo during the procedure and which are the different important steps. And I will finish by showing you a case in which we replaced the chordae apically, transapically in a patient with a mitral valve prolapse, which is not totally non-invasive. It's still a surgical technique, but it's on a beating heart. So when it comes out to mitral clipping, it is very important to define whether the patient is suitable or not suitable technically for the technique. Most of the time, those that are really suitable in terms of etiology are mainly now the ischemic ones or the functional ones, although you can tackle patients with mitral valve prolapse if the leaflet gap is not too large. Obviously, those with severely modified valve, like the rheumatic endocarditis or those with a prior surgery at this stage, are certainly not well suitable. The clipping will reduce the mitral orifice area, so and it can be sometimes significant if you place several clips. So of course it's important that you make sure already that your mitral valve area to start with is relatively large. For clipping, you need to have large leaflets. So the anterior leaflet is usually not a problem, but for the posterior leaflet, if it's very short, it may be a difficulty to clip it. So you need to have at least 1 centimeter. Preferably, you should not have either thickening or major thickening or calcification when you are in the area where you are going to grasp the leaflet. If you have some, it's feasible. If it's very severely calcified, I think it's a real contraindication. When it turns to mitral valve prolapse, obviously, you need to be able to clip the two leaflets at the same time. So if you have a very large flail gap, usually more than 1 centimeter, it may be technically difficult, not impossible, but if you beginners, it will be probably difficult, as well as if you have a very large flail, then it might not be the perfect indications because you have to clip several times at several different places to get a good coaptation. Now, if you are dealing with functional ischemic mitrals, then it's the severity of stenting that might be a difficulty. So if you have a coaptation depth which is very, very high, so if you have very restrictive valve, it may become a difficulty to grasp the two leaflets at the same time. Of course, it's a situation in which you are going to work on the left side of the heart, and particularly in the left atrium, so you have a lot of thrombi in there. It's probably a contraindication. Now, this is summarized here on this slide. You need to have a very small flail if you are tackling on patients with flail leaflets and mitral valve prolapse. If you have a very large one like this one, maybe it's preferable to do something else. The flail gap is also quite important because if the flail is the very large distance between the two leaflets may be difficult to grasp. And finally, in the ischemic ones, it may also be difficult to grasp the two leaflets if you have a lot of tethering. That means a coaptation distance that is more than height that is more than 10 millimeters. The question is, should you do that by transthoracic or transesophageal echo? Can you decide whether or not you can clip the valve only based on transthoracic? I think you can if you have good image quality. You see here several different cases. Here the coaptation depth was 10 millimeter by transthoracic. It was 10 by transesophageal. The same here, if you look at the flail gap, it was 5 millimeters by transthoracic and 5 millimeters by transesophageal. The valve area can be probably even better evaluated by transthoracic echo than by transesophageal echo. And the lack of coaptation, you need to have some degree of apposition of the leaflets, can equally be evaluated by transthoracic and transesophageal echo. So I'm not sure that transesophageal echo is mandatory to make the pre-intervention assessment deciding whether or not you can do it. I know that Abbott always ask for a transesophageal echo, but I'm personally convinced you can do it by transthoracic only. And it's the same for the presence of calcifications. I personally think that by transthoracic it's much easier to really locate the calcifications than compared to transesophageal, because transesophageal you're never sure to be at the tip of the leaflets, whether by transthoracic you can. So I think you can do the job by transthoracic echo. So once you've made the indication, at least the feasibility of the procedure, then you have to do the procedure, and it's, as has been said, it's procedure is done during total echo guidance, although there are some steps in which you can use fluoroscopy. Obviously, one of the most important parts of the procedure is is passing through the septum, and the location of the septal puncture is usually made at the echo guidance, and it's very important. I will show you an example. Then, of course, you can follow the dilatation and the placement of the dilator. You can look at the guiding, and then you have the advancement of the clip and the straddling, and it's very important during that procedure that there is no contact with the atrial walls, and of course their echo is really good at looking whether or not this is the case. Then, of course, you need to bend the catheter to bringing the clip at the level of the mitral valve, and then there is the release of the clip and the grasping, of course, before, which is all done during echo guidance. It's a good thing to use a biplane view when you do the septal puncture. You need to be relatively in the middle and maybe a little bit high here in close to the superior vena cava. Not too high, because otherwise you will be too far away from the mitral annulus and you have to measure that. And it's better to be located a little bit posteriorly than anteriorly. And then you have to make measurements between the annular plane. And if you are dealing with patients with a significant tenting, you should evaluate that tenting distance, because there is a certain distance to which you can advance the clip and not more. So if you are too far away, then the procedure is totally unfeasible. In one case, with a very large atrium of 12 centimeters, we have never been able to reach the plane of the annulus and to release the clip. 3D doesn't really help at this stage. It's essentially 2D echo that will do it. But you can use 3D to look at the septal puncture, to use 3D to see the catheter advancing into the left atrium, but this is more fun for imaging than for anything else. Straddling is a very important part, but straddling can be done with 2D echo. Here I've shown two 3D echo images of the advancement of the clip and then the beginning of the straddling, but honestly most of the time we're doing that during with using 2D echo, which to me is largely sufficient to do that. Now, clip positioning is very important, and usually what you do is again use a biplane view. When you're advancing the clip, you need to be exactly at the place where you are going to have the mitral regurgitation. If there is a lot of mitral regurgitation, you will first try to tackle where probably there is most of the mitral regurgitation, but there's also looking at the clefts in the mitral valve, which is important, because if you clip at some place, you may enlarge the cleft, so the strategy needs to be evaluated before. Then you see that when you're advancing the clip, it needs to be perpendicular to the line of coaptation, and that's an important feature that usually can be done by 2D if you go transgastric, but then you have to change your probe position. I prefer to do that clearly by using 3D echo, because the image quality is so good by transesophageal that you can really appreciate how the clip is turning on itself just to become perpendicular to the mitral valve. valve. Here is an example where the clip is relatively well positioned, and then if you are in this position and you're happy with it, then the clip can be advanced into the left ventricle, opened, and then there is the grasping. Grasping can sometimes, particularly in ischemic patients, but also in flail patients, quite a challenge. The amount of tissue on the clip needs to be sufficient so that you're sure that your grasping will be efficient, and then you have to verify before closing the clips that you are really perpendicular, because if you have a little bit of torsion, a little bit of an adjustment of your clip, there could be a lot of tension and the risk of course, tearing the mitral valve. Then, of course, when you're happy and the clips is being closed, you can release it, or you don't need absolutely to do that during under echocardiographic control, but this is a relatively picky endpoint there, so you don't want to damage the wall, so it's nonetheless quite important to look where the clip, when it will be released, at least the fixation will go into the left atrium in order not to damage the wall. Then when the clip is in place, you have to assess whether or not you have reduced significantly the mitral regurgitation. If not, assess the gradient, and if the gradient is not too high, you can decide whether or not you would like to place another one. What's on the horizon? There will be several talks on this. I will just talk about one technique which CE marked, and in which I think about 200 patients has already been done in Europe, which is the NeoCort technique. That's a very simple device that works like a sewing machine, and that will just perforate the mitral valve, put a Gore-Tex cord that will go in through there, then you bring both the end and the loop of the Gore-Tex cord outside, and you pass them through the loops, bring them to the mitral valve, and then you can anchor the mitral valve to the apex of the left ventricle. While you're doing so, you need to you need to find the puncture site, which should be relatively posterior so that the device can be advanced easily across the mitral valve. This is done the best on the 120-degree long axis view. You see the device and the head of the device, which is progressively advanced from the apex and from outside the thorax. Then you can make some adjustments so that you will not get into the AV groove there and just pass in between the mitral valves. This is going to be done right now. And all the advancements of the catheter is made under guidance of echo. Then the grasping of the leaflets will be done with 3D echo. There the echocardiographer has nothing to do, simply display the mitral valve. All these bubbles is when he's advancing the needle, because there are some bubbles in there. And then he grasps the mitral valve, close it, pass the needle through the valve, and then like the sewing machine comes back with the Gore-Tex cord. This is an example of a patient with a prolapse. Then you adapt the length of your Gore-Tex cord. As you see, the prolapse is disappearing when you push on the Gore-Tex cords. And then when you release them, you see that the prolapse comes back, and then the mitral regurgitation comes again. And you can do that also by three-dimensional echo. Here is the flail with the several cords. Then you pull on the single cord that has been implanted right now, and you see the prolapse completely disappear. The problem is that there is a lot of tension if you're only putting one cord, so there is a great risk of tearing. So in this case, we put 5 cords all along P2 with an excellent result. This was a guy who was in the ICU, impossible to weaning from the tube. He was a total contraindication to surgery because of his comorbidities, and we could not get him out of this cardiogenic shock, so we did that procedure, and he went out of the hospital 7 days later. So it's really a very nice and neat technique to cure a very large prolapse, because here probably we would have to put a lot of clips to cure that, and we may end up with mitral stenosis. So this is my last slide, essentially for the mitral clip, to remind you which we have to look at for the feasibility, the indication. Other people are probably going to talk about that. It should be a non-rheumatic valve with a large opening area, sufficiently large leaflets. If you are talking about mitral valve prolapse, the flail gap should not be too high. And if you're talking about ischemic functionals, then you need to know about the severity of tenting. Thank you very much for your attention.